Thank you, Ethan. It's a pleasure to be here today. And I'm going to talk to you a little bit about recommending against PSA-based prostate cancer screening, why I recommend against it for my patients, and why I would encourage you to recommend it as a wise healthcare choice for your patients. And I think, as you heard from Dr. Scardino, I think we could do a lot better. And I think if we did a lot better, even according as Dr. Scardino kind of outlined there, I think we really could improve the health of our patients. I think we all recognize that prostate cancer is a common and potentially serious and deadly disease. And what we want to aim to do is to improve the morbidity and mortality related to that with effective use of diagnostic and treatment options. So what's also, I think, really of interest is the tone and the content of the discussion from even as recently as this time last year. When I presented this information to the American Urological Association at their 2012 meeting, it was really met with a lot of resistance when the task force recommended against PSA-based screening for prostate cancer and that applied to all general U.S. populations. And I think as you're hearing today, really that there's been quite a convergence of the science and the recommendations. And I think there really is more in the area of agreement than disagreement. And I think it would be good to focus on a lot of the areas of agreement and then refine some of the areas of disagreement, hopefully with future science. So did the task force make the wrong call by recommending against PSA-based screening? Certainly there were a lot of opinion pieces written. This came out soon after, saying we should do one man at a time. Maybe we missed the mark on prostate cancer screening, maybe giving us a grade F on our prostate cancer screening recommendations, et cetera. But I think one comment that was really important was written by Gil Welch, entitled "Making the Call." And he argued that we often just kind of do whatever the patient wants, but that in reality, our patients expect from us some guidance as to what we believe is the science that guides them in their healthcare decisions. And as providers, we also expect our healthcare organizations to review the science and give us some guidance in helping us make the calls on what are the best treatment and screening options for them. And I think the task force took this serious and put this together as we made our recommendations. And in the past, screening has always been felt to be really kind of simple messages. And those would typically be, get tested, get treated. It could save your life. It did mine. And there were often powerful ways of communicating that message. Anywhere from men growing mustache in the month of November and naming that Movember to change the face of men's health, issuing postage stamps for prostate cancer awareness where they encouraged annual checkups and tests, or the production and wearing of blue ribbons commemorating prostate cancer awareness and often encouraging early detection and early treatment. But we know that those simple messages are only sometimes true, and it's even gotten through in the media lately. So the Consumer Reports, which I think we all value for assessing whether we should buy a car or what the best appliance is, et cetera, has now gotten into the area of choosing wisely, healthcare decisions. And on the cover story of one of their recent magazines that talked about cancer screening tests. Save your life with 3 cancer tests you need, plus 8 you don't. And one of those was the PSA blood test. And to communicate that message, they had a white, bald-headed, middle-aged man who would look very respectable. And you can see to kind of convey that level of respect, they have him wearing a stethoscope around his neck because he's a physician. And rather than encouraging PSA testing, he comments that he almost died from an infection he developed after a prostate biopsy. So I think the realization that screening can have downsides as well as upsides is getting through to the media, to our patients, and really when you read all the guidelines now, especially the ASCO's guidelines, I think you really see an appreciation and a weighting of the harms as well as the benefits of screening. So just by way of some basics, the goal of screening is to reduce overall and disease-specific death and disability, not just to find and treat more. But there are significant limitations. You cannot eliminate death from the target disease, and programs and interventions have harms. Implementation requires us to ask if and how about the health outcomes, both the benefits and the harms, the values for both the patient, the provider, as well as the health system and society. And while the task force does not consider financial cost, We as physicians, organizations, and the U.S. healthcare system needs to assess both the financial and the opportunity costs associated with screening. And achieving screening goals is difficult. Patients are asymptomatic. You cannot make them feel better. It's a promissory note that you are saying, trust me, I can help you feel better, live longer later on. But screening detects slower progressing disease, many which never cause problems, overdiagnosis. And that's particularly relevant to prostate cancer. And as we use lower and lower and more frequent levels of testing and more frequent biopsy, overdiagnosis increases, not only with prostate cancer, but with all our technologies. The vast majority do not benefit. If they benefit, it occurs in the distant future. But all are at risk for harms. Those harms occur early, often, and are frequently persistent and can be serious, and there is widespread overtreatment. Therefore, the burden of proof should be higher than for symptomatic individuals that we counsel. So screening recommendations really need to consider balancing the magnitude and certainty of the benefits and harms, that net benefit. So why does controversy exist? Well, I think there is real scientific disagreement about some of the evidence. How do you weight it? What do you include? What are the benefits that you look at? What about the harms that you consider? But I think in other areas, really, physicians and patients have been told to fear cancer more than any other condition that might occur, and that the only hope is early detection and treatment. It's hard for physicians and their patients to understand that not all cancers need detection or treatment, and that screening causes harms, not just benefit. There are powerful financial and legal incentives to test, and there's really no negative feedback loop. And few patient and provider tools exist, though that is improving. And finally, change is very hard. But when the science provides us information that changing practice will improve healthcare, we should change. I think there is one major area of agreement, is that the use of PSA testing by way of mobile vans or in free PSA screening clinics should stop. Or that in clinic you should not order a PSA as just part of their pan-man scan without showing them, telling them about that. And men should not receive PSA screening unless they have been fully informed of benefits and harms and request to test. That is really an incredible transformation of where we were at just a couple of years ago. And if we could even be with this, I think we would markedly improve the health care of our patients. Where areas of disagreement abound really are in what's the clinician's role in patients' rights? What does the task force and me as a physician really mean when we say we recommend against it? What about, does that prevent provider autonomy and patients' freedom? And should we do proactive counseling? Should every man who walks into my clinic office of that age be counseled about it? Should I talk about ultrasound screening for stroke prevention? There are 1,000 things that I could talk about. Why prostate cancer screening versus reactive counseling. If the patient or their spouse brings it up, then take that opportunity in my clinic time to discuss. What about the task force, including men most likely to benefit in the recommendation? Younger men and those at increased risk. So Peter's kind of discussed some of the areas that the task force considered in that. We and the other organizations really put the majority of the weight on 5, not just 2, but 5 major screening trials. And you can see those here. There are 2 considered to be at low risk of bias, the European and the PLCO study, but 3 additional ones that were considered of high risk of bias. But keep in mind, studies of high risk of bias tend to overestimate any benefit, not underestimate it. And while we were criticized by Peter for doing a meta-analysis, the task force did not do a meta-analysis. We evaluated those, but we really focused primarily on the 2 low-risk studies and described those independently. But if we would have done a meta-analysis, just like it's been done for breast and colorectal cancer screening with similar disparities between those studies, what you'd find is that there is no significant reduction in prostate cancer mortality, either with the low or the high-risk studies or overall. But let's just focus on these 2 low-risk studies. And Peter commented that we really looked at the ERSPC study prior to maturation. We looked at it when their latest publication came out through at least 11 years, and you see data out through 14 years. A 21% relative reduction in a core subgroup of individuals. Really, ERSPC is a meta-analysis of 7 different studies that really use different testing, interval, populations, intervention schemes, and really pooled the data with only a single data center. The absolute reduction was about 0.1%, the number needed to screen of 1,000. You can see that the curves begin to depart at about 9 years. The results really are driven by 2 countries with very high reduction rates. And it's really not clear why the reduction is as large as it is in there. Different screening intervals, different thresholds, different follow-up duration. But I don't think it's really of value to say that this one study is by itself the only piece of information we should consider. It's not likely to be replicable in the United States, nor do I think we should dismiss the US study, which has some problems. However, with annual testing, the risk of prostate cancer detection was 12% higher in the screened versus the control group. Yet despite that, prostate cancer mortality was actually higher, a 9% increase reduction. Contamination was an issue, but contamination will tend to narrow a benefit, not cause the curves to flip. Contamination cannot account for both an increased incidence and an increase in mortality. And results did not differ by age, comorbidities, or pretrial PSA. And when people say that these studies were too short, they were longer than any other cancer screening trials out there, or when we would expect to see a large difference. So if any benefit occurs, it's going to be off in the very distant future. The task force did not fully consider, but assessed it, population data. And if you look at the time for the curves to separate in data I'm not showing you here, the curves that Peter showed about the reduction in cancer mortality really cannot be accounted for fully by PSA testing. The majority of reduction in cancer mortality occurred prior to any impact of prostate cancer screening, if you look to see when the curves would change in the European trial. So what about weighing these magnitude of benefits and harms? PSA screening really does set off a cascade of events. At most, 1 man per 1,000 will avoid a prostate cancer death, but it is almost certainly much less than that. And we have to consider the major harms. Testing will pick up about 110 men with prostate cancer over the course of about 10 years, and at least double those that if you didn't screen. And about 90% of men are tested. And I think Peter is right, is that if there is new information, the task force will consider it about the potential harms of detection and treatment. But this is what's being faced now. Harms of biopsy are serious and frequent. 36 will have pain, bleeding, infection, 2 are hospitalized, and rare death. About 1 in 1,000 men who undergo a biopsy die from the biopsy, and those are not counted in a prostate cancer mortality in those screening trials. Therefore, it'd be even a smaller benefit. 1 in about 3,000 men will die. Peter mentions a higher rate than used. We kind of mention a variety of ranges for that, but about 5 per 1,000 in the Medicare population, or 0.5%. 3 have serious harms of a blood clot or an MI, and about 35 will develop erectile dysfunction or urinary incontinence. But the main harm is overdiagnosis. And as Peter mentioned, we published recently the results of the prostate cancer versus observation trial, which really asked the question, in clinically localized prostate cancer detected during the early PSA era, does the intent to treat with radical prostatectomy reduce all-cause and prostate cancer mortality compared to observation? And as Peter showed, we found no reduction in all-cause mortality through at least 12 to 15 years, with an absolute reduction of less than 3%. And the curves were stable, really, after about 6 years. So there is no evidence that the curves will begin to separate with longer follow-up. Similarly, with prostate cancer mortality, risk of prostate cancer death was extremely low, only about 7%. Curve separated slightly after about 10 years, but remained relatively consistent after 10 years. A hazard rate of about 37% reduction, but that translates out to a mortality reduction of about 2.6%. That was not significant. We really want to know about certain subgroups that did not vary by patient categories of age, race, or comorbidities. But what you notice is that there's a potential for there to be an interaction by PSA and risk categories. In particular, where it was strongest was PSA, less than versus greater than 10. And let me focus on that. Because when we looked at all-cause mortality for men with PSA less than 10, and Peter highlighted the data for men with PSA over 10, but the vast majority of men being diagnosed have PSA values less than 10. There was no reduction in overall mortality. In fact, it was slightly higher in the treated group. And this is observation, not active surveillance, which subjects men to harmful biopsies with no evidence of benefit. Similarly, for prostate cancer mortality, we see the suggestion of maybe an effect by PSA and risk category, though the risk category kind of varies and is really driven by PSA, not histologic grade or stage. And what you see again is for men with low PSAs, this includes all stages, all grades. If your PSA is less than or equal to 10, prostate cancer mortality is extremely low, less than 5%, and it is not reduced by surgery. We can reassure our patients, and we can do better with screening if we would not evaluate men with PSA values below 10. And the PSA values above 10, the median was about 15. So altering thresholds could really help out. So what does the science tell us? For age of 70 plus, there's convincing evidence of no cancer mortality benefit. For men 55 to 69, convincing evidence that any mortality reduction through 14 years is at most small. There's convincing evidence that the harms of screening and diagnosis are at least small, and that magnitude of treatment harms are at least moderate. So who recommends PSA screening? I think as mentioned, none of them do. It's really an issue about informed decision-making or recommending against. And so how do we implement that? Discouraging the use of screening tests for which benefits do not outweigh harms. But the task force and I recognize the common use of screening and understand that some men will continue to request and some physicians will continue to offer. The decision to initiate should only be conducted when men understand those benefits. And community and employer-based screening should be discontinued. So is it high-value, cost-conscious care, which is a good net benefit relative to expenditures? No. PSA screening is low-value care. It's estimated a lifetime cost of about $5.3 million, a cost per life year saved of $262,000, and that's based solely on the ERSPC study and assumes mortality reduction is overall equals prostate cancer and ignores quality of life reduction. So what do I recommend for my patients? I recommend against the PSA blood test for prostate cancer screening because the benefit does not outweigh the harms. I recommend we focus on areas likely to improve your health and prevent future problems while reducing unnecessary harms. I'll stop there. For most of my patients, they're fine with that. But if they want more information, I'll tell them. It's extremely unlikely that PSA will prevent you from dying of prostate cancer or help you live longer. Elevated PSA tests are common. They lead to additional tests that have harms. PSA testing finds many cancers that will not cause you health problems. And once we find cancer, it's very hard not to treat it. And treatments have harms that occur early, can be serious, and may persist, but have very little, if any, benefit. And by choosing not to have a PSA test, you can live a similar length of life, have little to no difference in your risk of dying from prostate cancer, and avoid test, procedure, and treatment harms. So how can we enhance high-value care? Recommend against PSA testing, but in those who still want it after you recommend, raise the abnormal threshold or widen the testing interval that will reduce diagnostic and treatment harms and over-treatment with little to no difference in mortality. For men with early-stage prostate cancer detected by PSA testing, recommend observation rather than early intervention or active surveillance is a wise choice. It maintains overall prostate cancer mortality and quality of life, reduces treatment harms, and there's lower resource utilization and healthcare costs that can improve your patient's health and reduce their anxiety. Thank you very much.